But this is one of the series of chats with our senior leadership, and I don't mean to call you senior in the bad
I'm relishing
way,
it.
Sue, but I'm going to turn it over to Alex here in a minute to introduce Susan. But Susan, to me, has been a real stalwart here at the clinic for many, many years. I've worked very, very closely with her in a variety of different areas, including the fact that she has saved me on many occasions with badly infected patients, which is something that I appreciate very much. But even more, she's been very instrumental in developing, nurturing, and moving forward our healthcare, primarily our physician staff, health issues in many different dimensions, and has been really an example of somebody who's a servant leader and who really cares about the clinic, cares about the people that are here. So it's a great choice to have you here, and I'm going to let Alex go ahead and do the formal introduction. I might say that these series are one of the student-led, student-organized series. Andy Bowen has been involved with that as well. We have him off working somewhere this morning, though. So we appreciate everybody to be here and look forward to a bit of an interactive session. Alex?
Thanks, Dean Young. So today we're lucky to have Dr. Susan REHM here with us. She's Vice Chair of Infectious Disease and Executive Director of Physician Health. She's been here at the clinic since 1983 after she finished a residency and fellowship here. Her residency was in internal med and fellowship in infectious disease. She was a member of the Cleveland Clinic's Board of Governors from 94 to 98, Associate Chief of Staff from 97 to 2005, and then became Vice Chair of the Department of Infectious Disease and Executive Director for Physician Health. She's done a lot of research specifically in endocarditis and affected cardiac diseases, or affected cardiac devices, which makes a lot of sense being here at the clinic, as well as the administration of parenteral antibiotics outside the hospital, which was a major development. She's credited with establishing the Cleveland Clinic's Community Parenteral Antibiotic Therapy Program, which lets patients recuperate at home while still getting IV antibiotics. She's also done a lot of medical education, conducting numerous workshops and webinars, and has many visiting professorships to her name. She was a program director for the Cleveland Clinic's ID Fellowship and Internal Medicine Residency Program, and she's currently a professor of medicine here at CCLCM. As Executive Director of Physician Health, she administers well-being, medical leave, and physician impairment programs, and she holds a certificate in executive coaching from Case Western's Weatherhead School of Management. And then from 2004 to 2015, Dr. REHM was the medical director of the National Foundation for Infectious Diseases, which is a nonprofit organization that educates professionals and the public about the causes and treatment of infectious disease. And she's also a fellow in the Infectious Disease Society of America and American College of Physicians, so she's kind of a big deal. So if we can give her a warm welcome, that'd be great. Thank you for joining us. So something that we're always interested in being medical students is, what was your experience like when you were in medical school?
Well, I am a graduate of the University of Nebraska, and at that time, we had a 3-year curriculum. It was designed to, and this is going to sound familiar, try to meet the needs of an expected surge in the need for primary care physicians. So they were trying to get people through medical school as quickly as possible. And they were also taking people after the 3rd year of college and then granting the undergrad degree after the 1st year of medical school. So that's what I did. It wasn't a formal 6-year program, but it had that flexibility, and as it happened, that's what I did. So I went to medical school year-round for 3 years, except for 1 month. And by that time, I was married, and my spouse was doing an out rotation at a rural hospital, so I spent my month off from medical school sleeping in an extra hospital room in a hospital bed. It was pretty exciting. But there were some interesting aspects of the training. Even at that time, I know we were short on cadavers, so I think we're 6-1 on in the cadaver lab. And we didn't have wet lab for histology. They had moved that to just slides. But the curriculum was oriented toward kind of studying cradle to grave for each part of the body. So when we were dissecting the arm, we were learning the physical diagnosis of the arm. We were learning what happens to the arm in clinical practice, the pathologic side. And I remember very vividly watching a video of a surgery that was intermedullary rod of the humerus. And they had the arm positioned like this and this rod about this long that the orthopedic surgeon was. And that day I decided I'm not going into ortho. But they tried to do this all, and we learned anatomy on each other. So they called it living anatomy. And yeah, obviously it was safe, arm no problem, leg no problem. But anyway, we were in small groups. The library was new at that time. I remember spending a lot of time there, and I hate to say it, but computers were not yet on the scene. So a lot of Kodachrome slides. We would have these huge Kodachrome slide sets and little players that we could use. It was part of the unique aspects of the curriculum at that time. I never did a rotation outside of Omaha while I was in, and this is just me being stupid, I guess, but I didn't even rotate at the VA, which was just down the street. Had a couple of out rotations at local private hospitals, and one of them had a computer system that was just coming up then. So that's kind of the milieu that I was in.
So what led you to Cleveland then?
The training. So
Train came to Cleveland?
yeah, the
Nebraska.
training was a real attraction here. So we did kind of an eastern route, and we looked in Chicago, Cleveland, Cincinnati, and so on. And the clinic was, the minute we stepped on campus, it felt like home.
That's great. And so what, after going through your residency here, led you to do a fellowship in infectious disease?
When I was, I'll say first, when I graduated from medical school, I had decided that I was maybe interested in reproductive endocrinology. But I also knew by that time I wanted to do internal medicine. What I hadn't figured out was that most people don't come at repro endo from that angle, so to speak. Nonetheless, as I rotated through as a resident in my first rotation as a second year, I was paired with a very charismatic attending named Marty McHenry, whom Jim knew. There were only two people in the infectious disease department at that time, Marty and a guy named Alan Weinstein, who, as it turns out, was the son of one of the gods of infectious disease, whom I got to meet, obviously, later on. But at any rate, Marty McHenry was a charismatic guy, father of 10 kids, and he treated everyone on the service, everyone in the department, like they were family. Pretty demanding. He would quiz us regularly on antibiotics, hand out articles. You always say, got to read it like a love letter, because he would quiz us on anything in there, including, what was reference 5 and all kinds of mundane stuff. He was a devout Catholic, and I would say that he approached the practice of medicine like a religion. Just totally devoted to it, really ministered to his patients, I would say, as much as anything else. And, a scholar and someone who instilled in me, or at least helped me recognize my love of trying to go from the unknown to the known. Those of you who have an occasion to do any chart reviews will find his notes in there. And Jim, I don't know what you remember about his notes. I mean, they're long, They are methodical. They
Handwritten.
are handwritten
You could
and
read them.
beautiful. Yeah, and he was such a machine. I remember many times standing at his shoulder while he was interviewing a patient, and he was very focused on the patients. He said, "Talk to the patients. They'll tell you what's wrong with them." Okay, that's good, because I don't know. He would be writing verbatim what the patient was saying. And when he got to the end of the line, if there wasn't enough room, he would start with the period on the first thing on the next line. That's how much of a machine he was when he was writing. But obviously, he was an inspirational guy to me, and so he solidified medicine was my route, and infectious disease was where I was going to go.
That's great. And so in that field, you helped the clinic kind of push forward a major innovation, and that's something that a lot of us are looking at, being physician scientists and trying to help shape the field with that home parenteral antibiotic therapy. Can you talk about how you developed that? Because I'm sure it was a radical idea at the time to give people IV antibiotics at home.
If I can leave you with one theme today, is that you never know what's going to happen on a chance encounter. And for me, as an ID fellow, and I must have been early on in the fellowship, I got a famous Friday afternoon call. It said, such and such patient is in the orthopedic clinic, they need their IV restarted, can you come over and do that? I thought, well, number one, I didn't know starting IVs in the ortho clinic was part of my job description. Okay. But as it unwound, it turned out that one of my staff, Dr. Weinstein, had sent the patient home on IV cefazolin, which is a 3-time-a-day antibiotic, and they really had no infrastructure. And I thought, okay, got the IV going again, and I thought, well, this is nuts. If we're going to have people out there on IV antibiotics, we better figure out what to do. Our colleagues in general surgery, led by Ezra Steiger, had established a home TPN program not too long before that. And so I talked with the team members from the TPN team, who included IV specialty nurses to maintain Hickman catheters, pharmacists. They had a link to various home care companies and so on down the line. And I thought, if we're going to do home IV antibiotics, we better get this team organized. So that was the nidus of it. And realize also at this time, there were many patients in the hospital who were there only to get plugged into an IV 2, 3, or 4 times a day. You literally walk in the room, young orthopedic patient and so on, and they'd say, why am I here? Why do I have to stay here? I could do this at home. And they could. One of the other innovations that we had was that we originally actually had patients mixing their own IVs at home. So you get a vial of antibiotic powder and some diluent and some bags, and they would do it themselves. And we really, the patients were actually more compulsive about doing it than probably the nurses and doctors in the hospital. They knew their technique, and one of the problems we had to deal with was that when they got readmitted for one reason or another, they would notice every little slip of the nurses or the people around them and call them on that, which the nurses didn't really appreciate that much, but it was a little bit of an issue.
That's interesting. So what was the initial response to trying to create that program?
Well, the clinic loves pilots, maybe even more than it loves innovation. And as a fellow, it was really under the radar screen. I think people didn't mind that it was being done as long as it didn't cost them anything. And actually, it was great because we're getting patients out of the hospital. In those days, like now, get more people through, get more urgent patients or more acute patients through so that they can get their surgery, get things done. So they were happy about that. But I didn't feel like, in retrospect, I don't feel like I ran into too many obstacles. People had enough time, the multidisciplinary team had enough time to be able to do that. I mean, we used one of our outpatient clinic nurses as a coordinator, which was an essential thing as well, and we started a record-keeping system, which was not computerized at first. We lost some opportunities on registry early on, I think, but I think it really didn't come on the radar screen too much until we'd set it up. It was a well-oiled machine, and we felt for quality purposes that these patients needed to be managed by the infectious disease team. There are many places where patients will, since I've already mentioned ortho 100 times, I'll say ortho again. The ortho surgeon.
I'm glad you're staying away from all those endocarditis patients.
There you go. Well, that's another story. But the ortho would come in and say, this patient's got a staph infection. I'm going to treat them with such and such, and order IV antibiotics and send them out, and I'll take care of it. We felt it was important for ID to stay involved for consultation on access issues, on following up on the antibiotics, following levels, that kind of stuff. We just didn't want anything to fall between the cracks. And we were able to make a case for this being a safety and quality kind of standard. Later on, we even built in a follow-up visit, or multiple follow-up visits. But the point is that we were getting some pushback early on from doctors who said, we don't want you guys anymore, bye. And we were able to, actually I was recently asked to provide this documentation, which since I never throw anything away, I was able to do. There was a medical division committee discussion which endorsed a mandatory ID consult for all of our home ID patients. It still comes up occasionally.
So that's where the evolution of the HIVAT consult came
Yes, home IV. So we called it home IV antibiotic therapy. And then a couple years later, there was this disease and this virus that was called HIV. And all of a sudden, people were saying, I guess we better not use that anymore. So in the bigger world, outpatient parenteral antibiotic therapy, or OPAT. We called it community outpatient antibiotic therapy because it was not only home, but it was nursing homes, it was rehab centers, it was other places as well.
Us older practitioners still call it HIVAT.
Yeah.
So when we call up, they know exactly what we're talking about, and they know exactly what era we came from.
Exactly.
All right, well, changing gears a little bit, you're also the Executive Director of Physician Health. Can you talk about the role that plays here at the clinic, and then what your role is kind of within that division?
Well, that role really goes back to 1997. I was on the Board of Governors at that time, but I was tapped to also be an Associate Chief of Staff. And Ralph Straffen was the Chief of Staff at that time, a really incredible, energetic, and very organized guy. So he had me come down to the office, and he and Rob Colton, who were the administrator of the OPSA office at that time, said, okay, here's the job. You're going to do diversity, and you're going to do physician health. And physician health at that time was a euphemism for manage impaired physicians. 5 years earlier, under a Joint Commission mandate, the clinic, like all hospitals in the country, had created a medical staff function, which was a committee to oversee the evaluation and management and follow-up of impaired physicians. So you can guess, impaired physicians are people who are unable to do their duties safely and effectively because of illness, drug use, or other issues. And so when I introduced myself to the committee, multidisciplinary group, they told me it was sex, drugs, and rock and roll. I thought, okay, we can handle this. But anyway, it was I don't mean to make it too light of it, because it was all impairment. So somebody might be found to be drinking at work or have other issues, would come to the committee. We would oversee their evaluation and recovery. And we usually follow people for at least 5 years after the event. We also took care of residents, and we continued to take care of residents under that committee. Now, what happened over time was that obviously there's always going to be people, unfortunately, who are impaired, but in business terms, they call this mission creep. We've had mission creep, which I think is actually good with the Physician Health Committee. So we gradually began to see people who weren't impaired, but weren't entirely well either. And now we are working on prevention. So like the healthcare world in general, we're trying to keep people healthy, give them a vaccine rather than let them come down with an illness, and moving forward there. So there's a lot of action in that area, but that's in some ways a much more difficult job. Impaired physician is a one-by-one kind of activity. Working with true physician health and well-being, which is where we're trying to push things now, is population health. It's population management, and it's, there are challenges of size, there are challenges of style, there are challenges of culture, and so on, but we're trying.
Great. All right, well, at this point, I'd like to open it up to any questions that you guys or girls might have for Dr. Rem about any of the things that she's done or anything else. She's ours until 7:50, so. Yeah, Chanmi.
Thanks so much for talking to us this morning. My question is regarding the access of information patients get these days, because in my experience from previous volunteering, actually a lot of patients look up what drugs they're taking, and as you mentioned, some patients are better at coming up with this cocktail of antibiotics. So how would you advise young doctors such as ourselves to kind of adapt to that? How do we actually correctly educate the patients when they come up with information they found online, but they're not necessarily true? So how would you kind of respond to that change in population of patients?
So to repeat the question and make sure I have it right, the question is about how we can, as physicians, help to guide patients with some of the information that they get, drug information and others online, and from other sources other than that. I think it's a great opportunity for partnership, and there's enough out there that many people do understand that just because you find it online doesn't mean that it's the sole source of truth. But you all have already or will at some point go through the Foundations of Healthcare Communications course, and you've got a whole year worth of communication skills building. But this is where using those communication skills is huge. The good thing is the patient's obviously engaged in their care. They are interested in what's going on. So you've got a starting point for empathy right there. This is really interesting. Where did you find that? How did you, and so on down the line. Oh, that's great. Have you seen this? And so on. It is admittedly very hard because there are certain conditions in particular where people come in and you may be the third doctor that they've seen, or the 30th, because they haven't found anyone else to endorse the interesting things that they've found to explain their symptoms. But I think so much is in taking time for that relationship. I've done it wrong so many times. I've been the smart person who's, that's ridiculous. That can't possibly be. And by the way, the psychiatry phone number is this. One particular population in infectious disease where this comes up all the time is delusions of parasitosis, right, which is so common that we call it DAP. And most of the time, patients will come in with a piece of lint or something that they found that they have looked up online. They know the pathogen. They know that they need an antiparasitic drug or something else. And, you know, we can send it to the lab and say, well, you know, we'll have someone objective take a look at this and we'll get a report and go over it. That it is actually a psychologic disease, which responds to a type of, sometimes responds to a type of antipsychotic medication. But there's so much online about this medication that they know that if they're offered it, that they're on to the next doc. So, bottom line, I think it's really, it's a great opportunity. Use the fact that they are interested in their health to build on that. Listen to what they have to say. That I go back to my mentor, you know, the patient will tell you what's going on. Just listen, and give them a chance. Give yourself time.
Thank you. Yeah.
So you started in infectious disease in the 80s, and so that field that you said you started, like there were 2 people in the department, and so in the subsequent years it's drastically changed. How has it changed, and like what advice would you give to us, no matter what field we go into, as to how to adapt to the changing landscape of our particular area?
So that's a great question, and the question is, how do you adapt in the changing world that you're put in? I guess 2 things. One is, as I mentioned earlier, you never know what stray comment or event is going to have a huge impact on your life. I go back to this time after time. If you follow your interests, you will discover things not only about yourself, but about the practice that you never thought possible. And the other part is to, if you possibly can, build in flexibility. Because, you know, we're all busy and we're going to be busy and so on. But that ability to just follow your interest, that one extra mile, or hear something differently that you hadn't heard before, may mean all the difference in the world. And you have to be open to opportunity as well. Not everything is going to work out. When I got called down to the chief of staff's office, first of all, I thought I was going to be fired, but you know, you just don't know. And I remember talking with one of my division chairs, not Jim, who was my division chair for a while, but one of your predecessors actually, and he called up and he said, you know, I want you to chair the search committee, and you know, it's going to be really exciting. And I'm thinking, yeah, right. And I literally was so busy that day I could hardly even take time to answer the phone. And I said, you know, I really think I ought to concentrate on such and such and not do that right now. I'm sorry. He said, Susan, I am not asking you, I am telling you.
You sure that wasn't me?
Well, you must have learned from him. Anyway, so take advantage of the opportunities that are there. And the other thing actually that has come home to me, and this is crazy after I've, you know, X number of years out of school and everything else, but this came through the coaching experience, that don't forget who you are. You know, we're doctors 24/7 and so on, but that's our occupation. That's not us. If you maintained a good sense of who you are, what your values are, what your priorities are too, all of this other stuff will become available to you. You know, you will see the possibilities in everything.
Back.
So with patient burnout being a big, or with physician burnout being a big issue, how do you still find passion in your everyday life in the hospital?
It's funny that there are tons of emails, articles, all kinds of stuff these days about burnout. And when the clinics started concentrating on physician well-being a year or so ago, I basically got called into a group. It's like, what are you going to do about burnout?
Fix it
Right,
now.
right. Well, I had ideas, but,
Another work order.
yeah, right. And recently, these articles and emails have been coming through. I don't know if you guys have seen them. It's like, is talking about burnout making people more burned out? So I'm not talking about it anymore. But I do think that's true to some extent. I think it goes back to the answer to the previous question too, and that is, if you know who you are, if you know where your values are, and if you can spend at least 20% of your time doing things that you love, you can power through the rest. And that 20% is not an arbitrary guess. There's been some empiric research done to show if you're doing what you love to do 20% of the time, you'll be able to make the rest of it work. But it is partly reflection too, and I haven't practiced mindfulness myself. I know that's another really great term that's floating around these days. And I think that we all find our own mindfulness in different ways. We do have to give ourselves permission to reflect in the middle of all this, because it's those quiet moments. Most of the time it's not, okay, 8 hours of work, 10 minutes of reflection, 1 hour worth of meals and so on. This is something that you can do, and I think it's most effectively done during the day, to just take time, take stock, take a deep breath, put it in perspective, and on to the next thing. Especially when those demands are coming at you. Learn to recognize what it feels like when the demands are overwhelming your ability to cope with it. That's huge. I can't tell you, on the impaired physician side, we sometimes see people who are disruptive in the workplace and so on. A lot of times that's because they're not necessarily reflecting on how things are impacting them, and it's coming out in a way that's destructive to the people around them. It's common, it's human nature, and it's part of, I'll say, physician personality. I hate to throw us all into that, but let's face it, we got through college and we're getting through medical school and our training and everything else by a certain set of characteristics, which include being somewhat compulsive, being attentive to detail, and so on down the line. Satchel Paige says anything that's worth doing is worth overdoing. I have to respectfully disagree with that, because when you overdo some of these traits, it's a time when it starts to spill over in a way that can be destructive in your relationship. I know Dr. Franco's got the cognitive behavioral therapy course that's an elective that she teaches, but these are the types of reflections I think that will be reinforced in that and other settings. I think your curriculum is actually so strong in terms of setting the stage to reduce burnout. I read your essays, I read the portfolios, and I am just totally humbled by the way you all think about what's going on. I wish that the trainees, the residents and the fellows and the staff had portfolio systems for evaluation, because I think it really helps people to think about what it is that they're doing and where they want to go. And you've got your personal development essays, which are a fun place to kind of think about where your profession fits into your personhood, in addition to reflective practice things. Take advantage of that. I don't see your formative essays, but many of you probably are using bits and pieces of your formative essays to go into your summative portfolios. But to me, I think about that. In coaching, I heard about some of the ways intentional change. We're so close to the Weatherhead Behavioral Management School that you have to think about it every once in a while. For intentional change, you've got to reflect, and having a formative portfolio is kind of like journaling. It's your process. So that's kind of a diffuse answer, and that's why the fourth floor doesn't like it when they talk to me about burnout because
They want it
what-
fixed now.
they want, okay.
Here's a
so,
pill.
That's right. Let us pay X amount and we will implement, we'll give everybody free dry cleaning and a meal every day,
Yeah.
and they won't be burned out anymore.
Take 2 weeks of
Like-
vacation now.
We do have something coming up, though, I'm very proud of. We are going for the professional staff. We are going to have a well-being day. And that will start in 2017, and it'll be a day that will be taken instead of a meeting day to do any activity that the staff member feels would be helpful in their well-being. So some
Nice.
people may, go over and have an executive physical or fill in the blank. But, one of the things that evolved from my physician health role was to manage illness leave and disability. And I thought, this is crazy. We've got people who are off for weeks and weeks and weeks, and we can't even give them one day to take care of themselves.
Right.
So this will get started.
I don't usually like to
Yeah.
jump in, but you just said something that really resonated with me, and you know me well. There's a lot of things that you do that resonate very well with me. But you just talked about passion and then delving into that, and one of the corollaries is delving into that and then coupling it to what we do every day. And as an infectious disease doc, just this morning, many people know I get here very, very early, and it's my private time. Don't knock on the door, please. but my secretary did this morning. But you also know that I have a passion for history, the humanities, literature, and whatnot. And I absolutely love putting together some of the presentations on these. I spent a lot of time digging around. And yesterday on rounds, we had a profound cardiac tamponade with a uremic pericardial effusion.
Oh, wow.
Something that, we don't see very much anymore. And in fact, when I picked the team up, the preceding team had kind of missed it, kind of took a delayed diagnosis because we don't see it very much. So I got fascinated in digging down into uremic pericarditis, uremic pericardial effusions, et cetera, because we don't see them as much anymore. And it was fun for me because I found out, who first described that? Bright.
Bright's disease.
Same person described Bright's disease, absolutely.
Yeah. Wow.
Post-streptococcal,
GM.
renal failure. And so it was fascinating putting, a picture and a spectrum to something that, I'll be taking care of that patient here in a little while.
Yep.
And to me, that's what helps me get through the long days, the hard work, the stress. So it's going to be really fun because I got Bright's paper, so I'm going to take it over.
Yeah, the team's going to love it.
Team's got to read it,
Yep.
and hopefully they'll remember.
Well, I love what you said about that, and there are many, many days when I think, what pulls me up is being with patients. And patients I see are really pretty sick sometimes, but being around the patients and their families is truly inspirational to me. There's some literature now in what emotions are physiologically good for you. So awe is one of them, A-W-E, awe. Compassion is another one. And, we are surrounded by those opportunities to be brought up. And that's where I get my energy. And that's where I spend a lot of energy too, but that's okay. I mean, it gives back in several fold. And it's so funny you bring up uremic cardiac tamponade, because when I was on nephrology, which was my first rotation here at the clinic, I saw a youngish guy who had presented with renal dysfunction or something, and I think he got an IVP, which is a test we don't do very much anymore, intravenous pyelogram, but it was a very large dye load. And because of the proteins that he had in his system, he went into immediate renal shutdown. He was only 45, and I think he had multiple myeloma. Anyway, he had uremic frost in addition to some tamponade. Uremic frost is when the urea actually crystallizes on the skin.
Right.
So you could see a little bit of a sheen on him, but the thing that I will never forget, because of where the proximity of the memory part of the brain to the olfactory part of the brain, is what it smelled like. You walked in that room and it smelled like urine.
Right.
Creatinine was
Fascinating, yeah.
23.
Yeah.
You just don't see that anymore. Yeah.
I didn't mean to trump on your
No,
questions
no, no, no,
there.
no. I think that's perfect.
Erica.
What sort of lessons have you learned from taking more of an administrative role?
So, the question is, what lessons have I learned by taking a more administrative role? I think number one is I've had additional empathy for administrators. Because
Thank you.
it's easy to say, well, they should just change that. It's hard to do sometimes. So that's clearly one of those things. And I've thought a lot about how one is effective both in an administrator role as well as in a consultant role, because to me they're similar. Being a clinical consultant, I think there's a lot of communication involved in that. There's a lot of packaging, knowing your customer. You know, how can I present this problem formulation and suggested therapy in a way that it is, number one, going to be heard, and bonus, acted on. So I had a lot of practice with some people who are currently leaders in our organization when I served as a clinical consultant to them. And I learned that some people don't want to hear all of the fabulous things that I have determined during my lengthy infectious disease consult. Some people don't want to hear that they were on vancomycin from June 2nd until June 15th. They just want to know what's going on, and do you think that we need to operate? Okay. You see them glazing over, that's it. So from the administrative side, I think you think about how do I package things for communication? How do we make this something that people can understand and that is actionable? And I think the other thing that I learned and continue to learn is that there aren't very many people anywhere who can make big slashing sudden changes. Most changes are incremental, and that's really the way it should be. I think it's for most circumstances, because culturally it's a little bit easier to make repeated small changes than it is to say, okay, it was white and today it's black. But it takes time. It takes time, and it takes a ton of communication.
I think in a nutshell, a concept is that if you look at evolution, it is much more permanent and longer lasting than is revolution.
Nice.
With rare exception, maybe 1776 was one of them, but it's only been 200 some years ago. Revolution does not generally end up with permanent results. Evolution does, so slow, incremental movement forward. And sometimes we get frustrated with that. And, you know, we push for an immediate kind of change.
Yeah, it doesn't
So
go
that's
over
a great
well.
answer, great answer.
Yeah, I was reading Kearns Goodwin's Team of
Yeah.
Rivals recently.
Great book.
And, you know, it came out 10 years ago. Why didn't I read it then? I don't know. But I was just
paperback
reading
now,
it.
you know?
Yeah, that's right. I got it from the library. By the way, we have such a fabulous library system here. Use it. So, of course, I was thinking about it partly in the context of the current political situation in the United States, but I certainly think about it in the context of the clinic as well. Because we're not necessarily all on one page, but my gosh, the power of bringing people together who have different points of view, huge. You know, and it's the one reason I stay here. You know, that it is that opportunity to, in a safe place, really have conversations about how we can move together on ideas that we believe in.
We've had the great opportunity to hear about a lot of the successes that you've had, that have meant a lot, and you've had a string of them in different areas throughout your career. Are there any particular failures that have meant the most to you? Would you like to comment on?
So the question is, we've heard about successes, so how about failures? There have been too numerous to count, as they would say in the microbiology lab, TNTC. Yes, and I would consider my time as internal medicine program director not one of my shining successes. We have a huge internal medicine program, as you know, and I was overwhelmed with it. And in retrospect, and I knew this actually at the time, because of how I approach things, I spent probably 95% of my time with the 5% of people or situations that were problematic. And I feel like I lost the vision thing because I was too kind of individual and individual task oriented. So I learned through that and other experiences that I need to set up support infrastructure that I can live with and be comfortable with and give it away, not micromanage, but give that away to try to maintain the vision thing. And I do struggle with that all the time.
All right, I think we have time for one more question. We have one out there. Yeah, Daniel.
So you are Executive Director of Physician Health. So could you talk about your initiatives you've taken as you progress in that role? You said that you've done some new things, especially for well-being of physicians over the past year. Could you explain that?
Well, I'll say Wellbeing Day is like the most visible thing that we've done. But we've tried to build bridges between various entities. And so, for example, the Patient Experience Institute or group has a number of initiatives which have an impact on physician health directly or indirectly. And it mostly is in the realm of the how patient care situations impact us emotionally and physically as well. So, for example, they've had a few patients in the hospital who were there for not months, years, who have had abusive families, and all of the caregiving staff was impacted by that. They have gone in and had some interventions. We've gone in, worked with them as well. So bridging with multidisciplinary teams, including patient experience, graduate medical education. We have a subcommittee on trainee health and well-being. We interdigitate with the medical school, although we are not directly responsible, but we've tried to and appreciate having dialogues about that as well. And with HR, now this is kind of a clinic political thing, but there's continued growing pains about even the use of caregiver. You know, we treasure our interdisciplinary groups, but there's some of the doctors don't like being called a caregiver. They feel it doesn't show adequate respect. So we're trying to manage all of those interactions as well. Keep that interdisciplinary dialogue going on and move it forward. And the problem is that many of these initiatives are not, today we're going to do this. They are ongoing little iterative things. Since the onset really of my involvement in physician health, we have had a very tight connection with our employee assistance program and have expanded that through our efforts. We've gotten support from the Professional Staff Affairs Office to hire additional people who work in physician assistance. So we are totally integrated with that employee-based employee, based system, which is a great model for where we need to go with all of our initiatives, health and otherwise, going forward. But it's been done sub rosa, so to speak. It's been done just interstitially, and people don't know about it. But that's what we want to continue to do. We want to continue to build bridges.
All right, well, thank you to all of you for coming, and let's thank Dr. Rem and Dr. Young for being here. Now go to class.
Time to get up there.